morning, everyone. The aim of my presentation is to discuss long-term outcome of pediatric cataract surgery in infants. So while IOL implantation is the norm in case of adult cataract patients, in case of children and especially infants, it's a topic of controversy. While the results of infant efficacy treatment study do not favor IOL implantation in less than 7 months, probably because of high rate of adverse events and subsequent surgeries. They advocate that the patient should be left aphakic and subsequently be treated with contact lenses. But in scenarios like ours, poor compliance with contact lens use and poor hygiene does not make it a suitable option. Fewer case studies from developing countries actually favor IOL implantation in such patients. One such study done at our center showed low case of adverse events and additional surgery requirements in IOL implantation in infants at a follow-up of 3 years. This study is actually a follow-up, 5-year follow-up of the same patients. The primary objective was to study the visual outcome, and secondary was to study the number of complications and the need for secondary interventions in such patients. This was a retrospective study done between 2010 and 2016, and all the patients of congenital cataract who underwent IOL implantation with a minimum follow-up of 5 years were included, but in those in whom IOL could not be implanted were excluded. So after an informed consent, the parameters which were evaluated for these patients included visual acuity, a change in axial length, myopic shift, and other complications such as intraoperative and postoperative complications. SPSS software was used for analysis, and coming to the results, 71 eyes of 42 infants were included, with the mean age being 6.4 months of the patients, and the average follow-up was about 5 years. 41 eyes got operated before 6 months, and 30 underwent surgery after 6 months of age. 3 patients had positive torch spectrum. The mean BCVA was 6/30 in these patients, and as high as 7 patients had a visual acuity of more than 6.12. The mean myopic shift was about 6.3 diopters in these patients. Ocular hypertension was seen in 5 patients, but none of them had any vision-threatening complications. No difference was observed in the visual acuity in less than 6 months and more than 6 months. The rate of secondary procedures was about 27% in the study, with membranectomy being done in 17 patients, IOL exchange in 1, and 1 patient needing pupilloplasty. These were the main factors which affected the myopic shift, with additional surgeries such as membranectomy, PHPV, and the first refraction post-surgery showing significant correlations. In our study, we took a difference of about 7 diopters as large myopic shift at a follow-up of 5 years, and these patients showed a change of axial length as high as 5 mm. A main association which was seen in such patients was that of secondary procedures, with patients who underwent membranectomy showing a myopic shift of about 8.9 diopter squares. So to conclude, primary IOL implantation can be taken as a safe option in such patients, and in our study, optical visual outcomes and lower rate of surgeries was because of rigorous post-operative topical steroid therapy. In IITS had actually shown a high rate of glaucoma also, but just the placement of an IOL should not be taken up as the reason for increased IOP, and other factors such as surgical method and other ocular abnormalities should be given adequate weightage also. And as in our study, membranectomy has shown a positive correlation. Therefore, a good cortical cleanup after a surgery and other alternative methods such as posterior optic capture should be thought about to avoid a high myopic shift. Thank you.
Shubham, you are doing residency there now, or you are?
Sir, I'm doing final year student.
Final year. So 2010 to 2016, you collected the data. 5 years follow-up 2021.
Yes.
So it has been 2 more years. You have published this or not? This data?
Not yet, sir.
Why? Sublime ma'am did not help you in this?
Sir, we are pursuing it. We actually are planning to submit it.
Okay, you should do it earlier, na? Because see, I can calculate whatever you told. We have not forgotten. So you should publish it very early. Otherwise, it will be old. Somebody else will publish. Okay. Thank you.
You have a good case series, so you should put it out there for every, because a lot of people are still leaving these babies a fake egg, so when you have significant data, it also becomes your responsibility to put it across to the other pan-ophthalmologists out there.
It's in the pipeline. We are planning for it.
Yeah. Very good data.